that in a trauma setting, we have some parameters that we should be adhering to, right? So the Platinum 10 is used to call it, right? So the amount of time we're on scene doing those previous things that we just talked about with that patient and how fast we can get them on the road en route to potentially a trauma surge.
Engine 23 and Medic 23, Larpenteur Avenue West and Fry Street. Police on scene. Shooting. Stand by for police. Box 546. On fire off score. Time 21:07.
Hey everyone, welcome to EMSconnect On Shift, your go-to podcast for everything EMS. Sometimes we're going to educate, sometimes we're going to review EMS articles or books, sometimes we just hang out with badass people and BS, but I'll tell you what, every time we're going to have an absolute blast. I am your host, Shaun Pitts. I'm the head of education for EMSconnect. We are a top-tier EMS education organization that offers more education than you'll ever need. We have a website with hundreds of hours of education. We got online EMS refresher courses, and we even offer on-site courses. Before we jump into this episode, please take a moment to go to whatever app you're listening to this on right now and subscribe to our show, give feedback, and give our show a rating. Every rating you give truly elevates this podcast and makes it easier for others to find us. Please help us spread the word about EMSconnect and the On Shift podcast so everyone can get educated.
We got Nathan Denison. Nathan, go ahead and introduce yourself real quick.
Yeah, I'm Nathan Denison. I am Director of On-Site Education for EMSconnect and EMT instructor. Previous experience as a paramedic educator. I am a firefighter, paramedic, and lieutenant position for a local Spokane agency.
Well, let's go ahead and let's get this started for trauma assessment. So our objectives get out of the way. We're going to kind of go over just at that 10,000 foot view of what our trauma assessment is. Talk about vitals, what's important, what's not important. I love the checking CMS or PMS, depending on where you took your education. That vernacular has changed just a little bit. Got a couple of great case studies to talk about. What are we going to do with this? I love some of the stuff on mass casualty with some of the new guidelines and things like that with that for triaging, and then post-test as always.
All right. Yeah. So to start out our trauma assessments, kind of that, like Shaun said, that 10,000 foot view, like what are we getting ourselves into? And this goes again to our dispatch information, right? As we get that call that comes in, however you take that, dispatch is going to tell you you're going on something, right? So we got to figure out what we have, right? Is this going to be a medical call, a trauma call, maybe a little bit of both, right? So when we get there, we're going to start our assessments. Obviously, we're going to view the scene, make sure that it's going to be as safe as possible for all parties involved. And then we're going to start diving into our patients, right? So we have kind of the rapid trauma assessment, a quick overview of what's going on. Remember that on the trauma side versus medical side, we have an X before our A, B, C, D, E's, right? So X being exsanguinating hemorrhage, any massive bleeding that can kill somebody quicker than you can get your hands on, right? And we kind of took from the military their March acronym, and I think it works great in the trauma setting. Does lend itself to help us out in the field, right? So after we do our rapid trauma assessment, then we kind of go back and we do our focused assessments, right? So looking at our vital signs, trying to figure out, how alert they are, going through those, samples, OPQSTs, all that kind of stuff, right? So do our focused exam. Then what can we do as EMTs to help this patient out, right? Do we need to bandage something, splint something, C-call, or, you name it, we might have to do it, right? And then lastly, and the biggest push is time, right? So we know that in a trauma setting, we have some parameters that we should be adhering to, right? So the Platinum 10 is used to call it, right? So the amount of time we're on scene doing those previous things that we just talked about with that patient and how fast we can get them on the road en route to potentially a trauma surgeon. And then we have that golden hour, right? So, and this is all based on when we touch patient, right? So depending on where you're at, right, that call comes in, it may take you a little bit to get to that patient wherever they're located. And so we are behind the eight ball on trauma patients specifically, right? Especially if we're talking about a significant traumatic injury, like we'll see in couple of our case scenarios later. We're a race against time, right? So one of the things that maybe a consideration is when you get on scene and you go to initiate patient care is somebody starts a timer, right? So either you go through your dispatch, have them start a 10-minute timer, or whoever's taking or recording vitals and assessment stuff, maybe they start a 10-minute timer. Somebody should be keeping track of time because we have a tendency to get involved in patient care, and specifically if they are a significant trauma patient. We want to do everything there on scene, or we think we need to do everything there on scene. But, we should have somebody who has that 10-minute timer. When that goes off, we say, where are we at and why aren't we on the road yet? Right? Remember, there's some things that we're going to talk about that we want to get done on scene, but what can we do in the back of the ambulance as we're moving towards where they need to be going to a hospital, to a trauma surgeon?
Yeah, and I think it's a great point just to bring up again of the 10-minute timer, whether that's on your cell phone, whether that's a stopwatch, whether it's the team lead, whatever the case is, having that 10-minute time frame because it's easy to lose track of time.
It is super easy.
And so then when you're worrying about that time, you have to prioritize what can be done here and what can be saved to the back of the ambulance.
Exactly.
Is it a better option just to throw them on a backboard? Not literally, but move them to a backboard, use that backboard to move them onto the stretcher. And then maybe that backboard is removed. They're now on the stretcher. They're in the back of an ambulance. They're headed towards a hospital, whether that's a 5-minute transport time or a 45-minute long transport time. And then we can worry about SAM splinting or box splinting or triangle bandages and things like that.
Yep.
We are going to talk today about tourniquets and, combat gauze and chest seals. Those are the things that realistically should almost always be done prior to transport and getting moved towards the hospital. So prioritizing what's important is what we're going to cover.
Yeah. And remember that, these are ideal times, right? We don't work in an ideal setting. So there will be times where we're at our 10 minutes and we're like, okay, why aren't we on the road yet? Well, maybe it's distance from your ambulance to where the patient's at and vice versa, getting back to that. Maybe patient has to be extricated out of a vehicle and now, that's a delay. So, but set those times just so you know where you're at. Right? 10-minute timer goes off like, hey, we're not on the road yet. Why not? Well, we're still trying to get the patient out or, whatever. We're not back to the ambulance yet. All right. So that march we just mentioned, what does it mean? So massive hemorrhage, airway, respiratory or respirations, circulation, hypothermia, right? So this is what the military uses as their kind of paramount field treatments. Again, like I said, the trauma assessment, the X being exsanguinating hemorrhage, what's going to kill them fast, right? So what does that actually look like? Are they bleeding? Can we see it, right? Do we walk up on a patient and there's a pool of blood around them? That's pretty apparent. But are they bleeding and how bad are they bleeding? In order to do that, we have to look at it, right? This is very hands-on technique, right? So if we can't see it, let's expose them and see if we have any, especially if there's a mechanism of there should be some bleeding. Let's find it. And if we can find it, can we control it, right? Is there a lot? Is this something we need to address now? Or, is it a paper cut and we can deal with it later? Can we control it? How do we control it? And does it need to be done right this second?
The MARCH acronym is kind of bookended with two things that they go hand in hand, right? But they also, one works against the other one. Exposing massive hemorrhage leads to hypothermia.
Exactly.
So do so because it is number one.
Yep.
But don't do it with absolute throw caution to the wind. Cut clothes, right? Maybe, if you're going to cut pants, you don't have to cut the pants all the way off. You can cut up the front of those pants, open up those, big, large body cavities, take a look, but leave the groin area covered, throw a blanket on the patient, and then let's move the blanket on the left leg, look for some injuries, cover it back up, look on the right leg. Like we don't have to just cut all the clothes off, make this person freezing cold, and then not think about the book ended at the very end of this with hypothermia control.
Yeah, exactly. Yeah, we strip and flip, right? But that doesn't mean we just leave them out for exposure. Right? We want to make sure we cover them up. Airway, what does it look like, right? So is it open? Is there something obstructing it? Do they have teeth missing? If they're unconscious and doesn't look like their airway is patent, meaning they're in an awkward position or, heads down or anywhere that can obstruct a normal tidal volume breath. What can we do to fix that? And again, remember in the trauma setting, we might have to be a little bit careful, right? So normally we use the head tilt chin lift, but in this instance in the trauma, do we have to use the jaw thrust maneuver, right? So we want to open our airway and we want to look inside, right? So if we have a mechanism that potentially has facial trauma, Are we missing any teeth? Is there blood in the airway? Is their tongue, which is the largest obstruction? If they're unconscious, their tongue is going to be the largest obstruction that we have. And is there anything else that's blocking the area that we need to address, right?
And with airway control, the NPA is vastly underutilized. And I think because the reason is early on, right, we were taught any sort of signs of head trauma, it was contraindicated to use nasopharyngeal airway. Depending on what your protocol allows, that's not always a sure contraindication. If we have cerebral spinal fluid coming from the nose, then absolutely. Cerebral spinal fluid coming from the ears, then maybe. But other than that, just because they have trauma to the head, it doesn't always mean in all protocols that NPA is contraindicated.
Yep.
Because if they have a gag reflux, OPA is 100% contraindicated. And at the BLS level, those are our two, options besides a supraglottic airway in some incidences. So don't, know your local protocols when it comes to using an NPA to assist you in this airway control with the MARCH acronym or with the XABCDE acronym.
Yeah. And practice what you have, right? Make sure that you're proficient at it. One of the things is, especially specifically for the NPA, is we need to lube that, right? Because we can cause some trauma as we place it if we're not doing it correctly, or if it's, causing friction as it's going in the nasal passage. So just be familiar with it, practice it. It's pretty non-invasive. So next is respirations, right? So we looked at the airway. Is it open? Is it patent? Is there anything we need to do to address that? And then how effectively are they breathing, right? So we talk about this too slow or too fast. We know the normal respiratory rate for an healthy adult patient is between 10 and 20. So anytime we have slower respirations than 10, we need to be concerned about what's going on. And I would say in the trauma setting, if somebody has sustained a significant traumatic injury and they're not breathing fast, I'm concerned, right? So that 20 top end range has a little bit of variance, and you need to know why. Why are they breathing fast? Anytime we're in pain or we're trying to compensate for things, we will tend to breathe a little bit faster, just automatically. So don't be too afraid of that. But if they're breathing too fast, and then goes into our next one, shallow, if they're breathing, 30 times a minute and it's shallow, they're not getting good tidal volume, meaning they're not taking enough oxygen in to exchange in the lungs to, blow some carbon dioxide out, and they're not going to perfuse their end organs sufficiently. What can we do to address that? And then the audible noises, can we hear anything obvious, right? So stridor, you can hear wheezes if somebody's has something going on in their lungs, or are we not hearing anything at all, right? Which is a bad sign. That's not a normal sign.
And I think this is another one with airway that we overlook as respirations. We're going to talk about the lethal triad.
Yep.
And the buildup of acid in our bloodstream. Now, at the paramedic level, combating the lethal triad means something different. But at the BLS level, one of the things when it looks at acidosis, if our patient is not breathing effectively, we're going to start changing the pH level of the bloodstream, right? So ensuring that we're aggressive with our BVM. When I mean aggressive, I mean noticing the need for a BVM, not the volume at which you deliver, not the rate at which you deliver. It's just making that decision, pulling that trigger to use the BVM. So look at this, measure their breathing, look at their tidal volume, and be aggressive with, do we need to use a bag valve mask on this patient? Because with too shallow, now we're talking about the buildup of acid in our bloodstream. Therefore, now we're changing the pH, which is going to lead to poorer outcomes. We may not even see the consequences of those actions,
right,
but our patients will see, and the hospital will see the consequences of us not being a little bit more observant and aggressive in this process.
Yeah, that's almost a guarantee, right? If we're doing all things effectively out in the field, we're getting the patient in route to the hospital, we deliver them to the hospital in a good time, we're probably not going to see those issues that arise later. But when you do a follow up and they say, hey, that patient actually expired, you're like, well, I don't understand why. And then we weren't paying attention to the respirations. So remember, again, this is a very hands-on thing, right? So do we have to feel the chest to make sure that we have equal chest rise? We have to actually count. I want to know specifically what their respiratory rate is per minute. So we need to be paying attention to that. So moving on in that MARCH acronym, circulation. So are we perfusing end organs is essentially what I want to know, right? So we are, again, hands-on feeling peripheral pulses. Our tendency is to go right to the radial pulse, right? So if we can, hey, is a radial pulse present? Know how to do that. Know where that's at. And if you can't, we need to figure out why. Ask somebody else, hey, I'm having trouble feeling this radial pulse. Can you feel that? Or do we have to go a little bit closer to the core, right? Remember, we're going to talk about shock states in a bit, but as we become shocky as a patient, our bodies will automatically shut down peripheral pulses, right? So we might not feel that from that radial pulse, and so we have to move on, right? But if you can feel it, how does it feel? Does it feel fast? Does it feel slow? Is it bounding? Does it feel like there's good pressure behind it, or does it feel thready, right? If you say, oh, I feel it, but I barely feel it, that's a significant sign, right? And we need to pay attention to that. All right. So talking about peripheral pulses, well, where the heck can we see them at, right? Or feel them at? So, we talk about radial pulses a lot. On some patients, you might be able to feel that ulnar pulse, which is, medial as they're in that good anatomical position. Depending on, again, size and age of patient, we can look for the brachial pulse. Remember, pediatrics, we feel their brachial pulse, more so than their radial, because it's
This diagram, that brachial pulse is a little on the low side.
Yeah.
So you want to be a little bit more kind of mid humerus on that medial side.
Yep. And it, on the medial side, tends to sit right in between the bicep and the tricep. So pretty good amount of pressure. It is a, sizable artery. So you should be able to feel it without occluding it. Carotid pulse. Again, everybody knows where the carotid pulse is. If you can't remember, feel it on yourself, feel it on your partners. We might even have to go down to the femoral pulse, right? And we utilize that femoral pulse in certain instances more on the medical side, right? And then, but when we're doing our full assessment, let's look at the distal pulses as well, right? So can we feel the top of the foot or that dorsalis pedis, or can we feel inside, just medial on the ankle, that posterior tibial pulse?
In this, it's important to remember circulation of the March acronym, right? This one, I don't really care about the rate, the number you're giving me, right? This is, are we perfusing to our extremities?
Yep.
Right? We'll have time to take a blood pressure. We'll have time to calculate heart rate, feeling for 30 seconds times by 2, or feeling it for the whole 60 seconds. This is, I really, really care about, are we perfusing? Is it bounding or is it thready? And then we'll get a chance to actually obtain some sort of heart rate. But it's important to remember that we're realistically just looking, are we perfusing to our extremities? That'll give us kind of an idea where we are in this shock state.
Exactly. We can start to anticipate a lot of things depending on whether you can feel a radial pulse or not. All right. Then lastly, we talked about hypothermia, right? We just talked about exposing the patient. Now you want us to worry about hypothermia. Yes. Again, Shaun mentioned the lethal triad, which we'll get into in the next slide, but hypothermia. So we know that traumatic patients have a tendency to lose heat fairly quickly, and it doesn't matter the time of year, right? So even, the hottest day of the year, if a patient suffers a traumatic injury, specifically, significant, in any significant amount, they're going to become hypothermic. Just the body's process of trying to fix itself versus not being able to fix itself. So, and that's any means necessary. Do we have coats, blankets, heated blankets, heat packs, extra bodies, the newest member on the truck, whatever you got. All right. So vital signs, these are important, right? They're vitally important. When we talk about blood pressures, most agencies have an automatic or an automated blood pressure cuff, right? We have monitors, either Zoll or LifePak 15, whatever you have. In a trauma scenario, I want a manual blood pressure. If we can get a good manual blood pressure to begin with, then we can compare it to the monitor. And if the monitor is not far off, then great. Because, if you have 2 people on a scene, of course, we're going to need more hands, and one person can't just be doing manual blood pressures every 5 minutes like we're supposed to, right? So these monitors that we have are great, but they can be fooled. When I say they can be fooled is, if there's any movement in that extremity while the blood pressure is taking, if they're tense, if they're doing anything, that can throw that blood pressure off, right? So, in the medical realm, we deal with this all the time. If a patient's not feeling good and they're holding their chest while we're trying to take that blood pressure with that arm they're holding their chest with, that's causing tension on that blood pressure cuff, and it's going to give you an abnormal reading, right? So in a trauma scenario, if we're dealing with that and we get a blood pressure back that's 120/80, the paramount blood pressure, but we have a significant mechanism that you would anticipate the blood pressure would be low, then there's a problem with that, right? So manual blood pressures, we need a good manual blood pressure to begin with, right? We talked about feeling those peripheral pulses. So now, not only, can we feel it, and what does it feel like, but what is our rate, right? We want to know our pulse rate because we need to be looking for signs of shock. SpO2 irregularities. So this falls into compensatory mechanisms, right? If a person is going into a shock state, they're going to start shunting peripheral circulation, and that can throw off our SpO2 reading. So are we getting a good pleth wave on our monitors? What are we looking at? And then what range are they in? Do we need to consider oxygen, or are they fine? Right.
When you look at most of the references on the dangers of high flow oxygen, right? You talk about COPD patients and the medical side of things. There's a emphasis on not using 15 liters non-rebreather for those patients.
Right.
But in the trauma world, there is some references that mentions there really is no science that says, that 15 liters non-rebreather increases survival or whatever the case might be. But in most cases at that BLS level, if this patient is bleeding externally or even bleeding internally, they're showing signs and symptoms of shock, be aggressive with that non-rebreather, right? With due regard, we're not going back to the 15 liters non-rebreather for everybody, but being able to notice that if blood is not inside the vessels, that is oxygen carrying capabilities, that is blood, and that is heat. So they're losing all three of those. We can't do anything about the blood itself, but we can help with the unloading of some oxygen, and we can help with maintaining that heat.
All right. So signs of shock, obviously we're looking at our patient: pallor, paleness, cyanosis, massive hemorrhaging that you didn't address. And then we got to be paying attention to things that can hide our signs and symptoms of shock, right? So that goes back into our sample history if we're able to get it. Are they taking any medications that would affect their blood pressure? Are they on any blood thinners that can speed up this process? Do they have a multi-systems trauma? So they are shocky, but they're also suffering, a traumatic brain injury or something. So that's going to throw their vital signs off. So looking for those, and then addressing as we can our trauma triad, right? So this is what it looks like. So the hypothermia, obviously we want to keep our patients as warm as possible. The coagulopathy, so as we bleed, we have clotting factors that can address that, right? We have our platelets that we talk about, but there's several other factors that go into the body's ability to stop bleeding, right? We only have so many of those at one time, right? Those have to be regenerated. And if somebody has some massive bleeding, then they're not going to be able to do that. So we want to stop that, right? So that would be addressing on all of our external bleeding, or anticipating the fact that they might be internally bleeding, which in that instance, we just need to be going faster, right? As we start to lose cellular oxygenation or respiration, then they start to break down. We can break down muscle tissue depending on what's going on. So we start to see a lactic acid buildup, which will throw our blood pH off. If they're not breathing effectively, like Shaun mentioned earlier, then we're going to build up carbon dioxide, which is exchanged in every exhalation that we produce. So that can start to get off. So we can address that through oxygen, and if we have to use BVM.
And EMTs tend to overlook this, because if you look at a lot of educational references, it seems to be very ALS heavy, right? But realistically, EMTs, we should own this 100%. Hypothermia is our realm, keeping them warm, covering with a blanket like we talked about before, putting a barrier between our patients and our backboards, or our patients and our stretchers is vitally important, because we're going to lose a lot of that body heat being transferred from our body to an object. Coagulopathy, we tend to think, not starting IVs and flooding them with fluids. Yes, in some states, EMTs are allowed to do IV therapy, which is great. But for us, you mentioned it, asking about any blood thinners or antiplatelet medications those patients could be on. Just knowing that they're going to have an issue clotting, I think, is vitally important. And then on the metabolic side, you hit it exactly like I want to talk about, using that BVM to ensuring that they are have a normal respiratory tidal volume is vitally important to combat that metabolic acidosis.
And then the bottom line, to decrease myocardial performance. So again, as we lose blood and we go into our different shock states, if we're not circulating enough blood, we're going to see end organ disruptions and tissue disruptions, which can, reduce our heat production, which will cause hypothermia. And then, it sits there and does a spiral until either we do something to stop one of those, or hopefully all of them, or we get lethal. All right. So just a couple tips. We talked about the CMS, PMS, whatever realm you use or when you went to class. So feeling peripheral pulses, we want to do this at the same time. I want to compare one side to the other, because that could tell, depending on the mechanism of injury, that could tell us something, right? So feel both of those at the same time, compare sides, whether you're doing radial or, distal, feeling the foot. Motor function, same thing, right? So this kind of falls into our fast exam for our strokes. I want to compare sides on that. Do I have anything nerve function, CNS function that's going to disrupt one side versus the other? I want to get equal on that. Sensation would be the only one that we want to feel one side at a time, right? So pick a foot, pick a toe, whatever, pinch, say, can you feel this? What am I touching? We don't want to do both of those at the same time, because you pinch both toes and you say, can you feel this? They say, yeah. Well, which side did they feel? We don't know. So do those one at a time, but the peripheral pulses and motor function, we want to check both of those at the same time and compare. And if something's off, please say something. All right. So again, just a brief review of assessments. And so now let's get into a couple of case studies to put this into action, right? All right. So case study number 1, we're responding to an 87-year-old female. She was walking outside, slipped on some ice, fell, landing on her right side. She has severe pain to the right leg. She's conscious on alert time 4. So what are our first actions?
Yep. So typical BSI scene safe, right? Walk up. My big concern in this case would be at the geriatric level, right? Any impact to the head, I think, is vitally important. We don't mention in this case of what the time of year is, right? But we got to be aggressive with the best of our ability. Let's be a 10-minute timer to have her off the ground as fast as we can with the proper immobilization and so on, keeping her warm. Maybe we put a blanket underneath her just to get her some sort of barrier between her and the outside environment, but then start down that march assessment, right? Any massive hemorrhage that we can see, airway appears she's conscious and alert, so we're going to assume her airway is open, right? Then go into that respirations. If she's conscious and alert, we're going to assume that normal tidal volume within normal limits of a rate. Circulation, we're going to check that CMS at those extremities on all 4 sides, and then treat for hypothermia, and we'll move as quickly as we can to the ambulance.
Yeah, that time of year is pretty important. Going back to our scene safety, right? So if this is middle of winter and she slipped on ice, is there other ice around that we need to pay attention to before we become patients and end up in pain like her? And it was good picking up on the, assuming the airway, respiration, circulation. If these case studies, if they're not specifically mentioned, then they are with the normal limit. So that was a good pickup. So we want to do that. And we want to get her off the ground and in the back of the ambulance as fast as possible. So going through our rapid trauma assessment, she didn't have any massive hemorrhaging that we could see. Airway, respirations, circulations was good. She had good CMS to begin with in all 4 extremities. She's complaining of 10 out of 10 right leg pain. She cannot move her foot, but she can wiggle her toes a little bit, does cause pain. So again, brief overview. We see that right foot is shorter than the left and is turned outward. So that's a significant finding for us. When we break hips, when we break femurs, that will cause some shortening and some rotations. In this instance, that's the case. So maybe we might, start building our differential diagnosis, right? Could be a number of things, but a fracture of sorts should be in our list there, right? So we're going to cut the pants. Don't cut the leg off. Cut the pants. And we do note some swelling right to the mid thigh. There's no active bleeding, but it is swollen. I'm sure, everybody picked up on this right away because you're genius EMTs, that she probably has a mid-shaft femur fracture, an isolated incident, right? So when we're talking about how we're going to treat this, traction splint is paramount on this, and for specific reasons. Why? Think about that femur is the largest bone in the body, most dense in most instances. In this case, if a patient has an isolated femur fracture, I want to know some other things going into our sample, like does she have osteoporosis, or is she on any medications that could decrease the level of calcium in her bones that could cause brittle bone disease? And is this true 100% without a doubt mid-shaft femur fracture, which the traction splint is meant for, right? If we have any evidence, or you're anticipating that there could be some femoral head issues or hip issues, then traction split's out. So this is just the ideal, 100%. I have no doubt in this. Hopefully the picture was painted well enough to say we have an isolated femur fracture.
That one is more on the distal side, right? Any sort of, if we're getting any fractures close to that knee, or a tib fib involvement or anything like that, again, the traction splint is a closed mid-shaft femur fracture, right? And even in this case, you look kind of at her presentation, she's fairly stable. So maybe a short transport, maybe you call medical direction, say, hey, do we even need a traction splint this injury, right? She's conscious and alert, blood pressure's good, that kind of thing. Longer transport, we're probably going to assume because we have P2 pulses present now, but we are concerned maybe with a longer transport, is this going to eventually cause some circulation issues? Then by all means, follow your local protocol, whether you're calling medical direction or not, to utilize this traction splint.
Exactly. Yeah. And as we're considering using a tool, we must understand how it works, right? So that traction splint, again, the femur being the largest bone in our body, holding up us on our legs, there's some good tension with all those muscles that are involved to help do that, right? So when we see a fracture, our body's automatic response is to tense up, right? So as it does that, we will actually pull the femur, it'll pull it closer, right? So muscles contract, pulls the leg closer. That's why we see that shortening. So we want to try and relieve that. So it can relieve some pain, but we also have a large artery that we don't want to sever, because then we'll have a different issue. Traction splints that we have, know your local ones, or whatever you have, use them, practice them, and again, know when we're going to use them, right? So the hair traction splint is, one of the, well, it's not my opinion, but it probably is. I like the hair traction splint. It does have some issues with it, right? It has to extend pretty far past the patient's extremity, and that can cause some issues when we're loading into the ambulance and or helicopter if you have to take them. But it's pretty good. The Sager traction splint, and then we have the tent pole Kendrick traction splint. So whatever traction splint you have in your agency, again, get it out maybe after this training, play with it, put it on. Know its limitations. And then the one thing about the traction is we must pull manual traction to kind of set this all up, and know that once you take manual traction, whoever does that has to be on it. So if you are short providers, maybe we talk with that patient, say, hey, we're going to help you in a minute after we get this traction split set up. It takes 2 of us to get it set up, and then take traction right before you do it. But once we take manual traction, we do not let it go until it's hooked up appropriately to whatever device that we choose.
And I think this isn't a splinting class, but we're talking about splinting. Is manual becomes before mechanical every time. Manual stabilization of the cervical spine before mechanical, which would be a C-collar. Manual splinting of, above and below the fracture with an arm fracture before the SAM splint or the box splint or the vacuum splint. So always manual before mechanical. That's going to be vitally important, because we don't want any extra damage caused by, unnecessary movement or the lack of stabilization when attempting to stabilize these injuries.
You chose whatever device you had. You pulled traction, had it set up appropriately. That did relieve her pain from a 10 out of 10 to maybe a 6 out of 10. So you're going to transport her. She's going to go to a surgeon. She's going to get fixed up.
And would you deem this patient to need an ALS rendezvous?
It's always a concern depending on, again, how far out we are, right? So yeah, if we have a distance to go, the traction splint is not going to take the pain 100% away. She just does still have a broken bone, which, the body's picking up on. But, I want my patients to be as comfortable as possible. So if you do have the ability, maybe we want to call ALS for some, medical control.
Yeah. Or if your agency allows BLS pain management, right? Nitrous oxide, Tylenol administration, any of those kinds of things.
Exactly. Whatever we can do. Before we move on from this patient is, yes, this appeared to be an isolated incident. But Shaun kind of mentioned this to begin with. Don't get fooled. Don't get tunnel vision down to one thing, right? We want to do our good assessments, making sure that this is the only injury. So good head to toe assessments, walking the spine, checking the head, making sure she didn't, mess anything else up as she fell. But because again, it does take quite a bit of force in most instances for that femur to break.
Yeah. And to remind ourselves, again, if they are on blood thinners,
right,
this call could be a little more critical than we think. And then not only is it just, yes, a femur fracture can bleed, but is there possibility of a head injury that is laying dormant or hiding somewhere we're not aware of? So know your local protocols of a ground level mechanical fall with blood thinners could be a trauma activation in some agencies or some protocols. So just know, like Nathan's saying, do a good thorough assessment. That's why I like the MARCH acronym, or the XABCDE acronym, is it eliminates tunnel vision. Start at the top of that algorithm, work your way down, overlook the entire body to ensure something's not hiding.
Don't get distracted by the distracting injury. Case study number 2, called to a local residence. We have a 65-year-old male who has a leg laceration after chainsaw use. That doesn't sound good. His wife calls in and reports that the patient is feeling faint and may pass out. So with this, what are our initial thoughts?
Well, this one, we're assuming that we're going to have some external hemorrhage, right?
Yeah.
As well as, unlike the other one, we have some involvement likely of respiration, circulation, or airway because we don't have a conscious and alert patient. We have someone who's losing consciousness. So we're going to assume it's being caused by one of those things.
That's great initial thoughts. And with this too, I would say where is he at, right? So chainsaw use, I don't think, maybe some people just walk around revving chainsaws and could cause issues, but is he up in a tree? What kind of additional resources may we need, and do we need to get them coming early?
Well, and the mechanism is important, right? If you know your area and you know this individual, like you're saying, is you're dispatched to an address that you know is going to be a 35 or 45 minute long response time, notifying the local helicopter service or ALS or something and get the ball rolling that direction, because we're going to assume this sounds bad. We're going to assume it's bad until proven otherwise.
Exactly.
So unlike the other one, I don't necessarily know I would be real aggressive with launching a helicopter. You could, depending on response time, but this one is one of those. I think it's important to remember location, distances to hospital, and assuming in this case, until proven otherwise, this is likely to be a fairly life-threatening injury in most situations.
Yeah, if he's got a good chainsaw, it's really good at cutting. So here he is. Good thing is he's on the ground. He does have his chainsaw right beside him. We'll say it is still running. So that is a scene safety issue we need to address, right? Move it out of the way. If you don't know how to shut it off, don't try. Just get it out of our area and make sure it's not going to bounce back to you. And then, he appears unconscious and we have a pretty massive cut on his leg. So we'll say that he does have a pretty good pool around of blood around his leg. So we do have some massive or exsanguinating hemorrhage that we need to address first. So there it is up close. That looks bad. And the chainsaw is still there. So we didn't get rid of it like we should. Would we consider this to be life-threatening?
Yeah, to me, location alone, right? If you go back one slide, location alone, we're at mid-shaft femur, right? We're on that medial side, meaning we're getting a little bit closer, a little less protection of that femoral artery. Chainsaw, that thing's got pretty sharp teeth. You can see the blood on the bar of the chainsaw. We got probably a pretty decent distance. This is, kind of chewed through the leg. We got pale skin. We have an unconscious patient. To me, this is absolutely life-threatening. And you would have to give me quite a few details to convince me otherwise.
Right.
Just because there's not any blood, there's no massive pool of blood. Well, those could be thick insulated jeans that all that blood is being housed inside of that pant leg. So just because there's not blood currently seeping onto the ground doesn't mean we don't have a giant pool of blood that's hiding from us.
We must anticipate the worst. And any incident involving a chainsaw, I would always anticipate the worst and say could be life-threatening if we don't do anything about it. So yeah, a good explanation of why or why not. Again, if you guys want to pause and talk about this with wherever you're at, absolutely, please do. How are we going to address this? A couple different ways. And obviously, when we're talking about bleeding control, direct pressure is what we want to go to first, right? So we have a great direct pressure bandage. If you have them available in your agency, the H bandage or the Israeli bandage, that causes good amount of pressure, but it doesn't cut off complete circulation. So with this, we want to evaluate and we want to not spend a lot of time evaluating, is our direct pressure working, or do we need to move on to maybe a tourniquet device?
Again, we don't endorse certain products, right? Israeli bandage, there is the emergency trauma bandage, there's the CAT tourniquet, there's the SWAT tourniquet, there's all kinds of, if you're looking for bleeding control devices for your agency, the Committee on Trauma Combat Casualty Care has a recommended equipment list of what is recommended by the military when it comes to bleeding control as well as tourniquet use, because there are non-approved tourniquets that end up on Amazon or things like that where you could buy them and they fail. They don't stand up to the test of twisting that and actually causing occlusion of those vessels. So be really careful with buying those devices, whether that's on your personal side or professional side care. So I think it's COTCCC. Will give you a list of recommended manufacturers of both tourniquets, as well as I believe on the emergency, like the pressure dressings, as well as the hemostatic gauze. So just kind of throwing that in there. Be careful what you purchase. Ensure that they're recommended.
Exactly. And maybe, call whoever you use as your supplier and say, hey, can we get a sample of every one of anyone available and test them out and see how you guys like them. Just make sure, again, like Shaun said, they're not Amazon knockoffs. In this instance, we do have some massive hemorrhage, external bleeding that we need to address, right? So let's talk about it. How are we going to do that? We just mentioned the direct pressure. If the direct pressure does not slow that bleeding down immediately, then we need to move on to tourniquet device. We need to practice both of them so that we're proficient at it. I'm not saying walk around and cut each other and then fix it, but you do you, but make sure that we're practicing applying whatever device you have appropriately and quickly.
And think about this transition, right? You're applying direct pressure and it says, well, if the wound continues to bleed, then you can escalate your means of controlling hemorrhage to tourniquet. But then on the other side, it says, well, don't uncover the gauze to look at the injury, right? So where you bridge that gap is you're applying direct pressure and your patient's shock is still progressing to getting worse. Our conscious patient is now losing consciousness. Our pale, cool, or our warm, pink, and dry patient is progressing to cold, cool, and clammy. Recognizing that you have stopped the bleeding to the best of your ability and it's not working. Now it's time to let's escalate those hemorrhage control means to possibly a tourniquet or some more aggressive direct pressure. It's not always, is the wound continuing to gush blood, because we should be covering that wound. That's the whole idea of direct pressure, is cover it.
Yep.
We don't want to look at it. We're not checking back on it every 30 seconds or anything like that. You have to be able to recognize what was your patient presentation when you got there. You've now applied direct pressure. If it's getting worse, that's not working, or there's another wound that's hiding from you that you need to go find.
Exactly. Yep. Just the pictures of it. So apply pressure with our hands, the provider's hands, or if patient's able to, they can assist, and especially if we're, limited resources on scene. So if that's not working, like Shaun said, we're progressing. We're not helping anything. We're not taking that initial bandage off, but we're going to move towards applying a tourniquet, right? So whatever, approved tourniquet you have, be familiar with it, know how to apply it correctly and quickly, and know that this does cause pain, right? So anytime we're occluding or applying really good pressure, our extremities distal to where we're placing that tourniquet will become painful. We need to have that conversation with the patient, and they might fight you a little bit. So use your words, communicate with the patient. This is not a painless procedure, but it is a life-saving procedure.
And we're not going to give any, there's high and tight, there's 2 inches above the injury, there's all kinds of references out there. Follow your local protocols of what they tell you. Exactly. If you're law enforcement based, maybe high and tight is what they teach you. Then do that. If you look at the American Heart Association and the Stop the Bleed campaign, they are 2 inches above the affected area, never over a joint. So you go 2 inches above that joint or whatever. Follow your local protocols of what your medical directors or your medical director delegates tell you as the standard, and follow those. We're not going to get into is high and tight better or 2 inches above or any of that.
The tourniquet has some bad raps in the past. So what are those myths, right? So tourniquets should only be used as a last resort. This was one from probably when I first started being an EMT way back when. It was that, right? The tourniquet was scary. Don't look at it. Don't talk about it. Don't even think about it, because, patients definitely going to lose their extremities. And we should only use this as a last resort after they've already bled out all over the place, right? So the truth, it does. They've done a significant number of studies, and they took all these studies from the military, right?
We got multiple slides coming up.
Yeah,
all kinds of statistics.
They've been used in the military for years. The ones who do need them the most, most of the incidents that they see were severe trauma, so they've been using them. Overall survival rate of 499 casualties in the from the Iraqi war was 87%, so that's pretty good. Survival rate only 4% if tourniquets were applied after shock was present, right? So this is the early anticipation. You do your direct pressure, it's not working, patients presenting like they're going into a greater shock state, move on to a tourniquet. Myth number 2, placing a tourniquet equals the loss of a limb. No. Actually, we do want to mark the time, right? There is a time component to it, but so we want to mark that time of when we placed it. But, looking at that slide there, we have the tissue damage following a tourniquet application, 2 hours, up to 6 hours. Hopefully we're to a hospital and they're in a trauma surgeon by then. But,
and we understand, for one, we're getting these images, right, from searches and studies and things like that. So there could be updated information that we're not aware of. We're not saying that this is the guaranteed, the one and only study, anything along those lines. But also we understand that some agencies listening to this might be a 3-hour time from time of injury to hospital. Very well could be 3 hours. situations of you apply one of these in the personal setting where maybe it's on for long, and we understand that. Like, we're not saying that in EMS, there's no way the tourniquet's going to be on longer than a certain length of time.
Yeah.
What we're just saying is this is the science that we have that says these tourniquets can be on much longer with no permanent damage than we initially thought. So if your agency still is a little bit kind of, feet in the sand, we're not getting tourniquets, we don't want to go that route. There's plenty of studies and science and statistics and articles that you can find that disproves almost every one of those.
And do spend the time, whoever's in charge of that, or if you want to take it on yourself, do spend the time to look into that research, because at the end of the day, we're trying to save a life, right? And we can only save a life if we stop that bleeding. A myth: belts make great tourniquets. Use what you have. Hopefully you have an approved device.
This is a picture taken from the Boston bombing of numerous improvised tourniquets. Now, do improvised tourniquets slow the progression of shock? Probably.
Yeah.
But are they going to shut off the massive hemorrhage? No, it's just slowing.
Again,
This is all you have.
Right.
Sure.
As EMS providers, we should come with the best tools available, and hopefully we have one. Myth number 4, improvised tourniquets are proper medical equipment. Nope, they're not. Doesn't mean that it can't, again, like Shaun said, slow bleeding, but these devices that have been made by medical manufacturers have been tested to make sure that they're going to do what they say. But there is a best tourniquet out there. Myth. Looks like there's several of them. So again, whoever your supplier is for your medical equipment, ask them about it if you don't already have them. So they do have some pitfalls. Well, you said they were great. Well, maybe not. So 8 pitfalls to avoid in hemorrhage control. Not using their tourniquet would be a pitfall, or waiting too long. So that patient, we do direct pressure, that patient progresses through the shock states to irreversible. That might be a little bit too late. Not making it tight enough will obliterate the distal pulse, or to obliterate the distal pulse. So again, when we're applying this appropriately, we do not want to feel a distal pulse, right? We don't want to have any, because that means that the bleeding is not stopped. Not using a second tourniquet when appropriate. Again, depending on the site or the injury, you might have to use more than one. So do so quickly. Periodically loosening the tourniquet. Once they're applied, they're tight, they're working to effect. Do not remove them, but we do want to make sure that they still are tight. So as we, apply a tourniquet and we have to move a patient, we want to periodically make sure that it's still tight and make sure it's still working, so that it doesn't loosen up on its own or move around. Packing a wound with hemostatic gauze product and assuming you're done, not necessarily. We do want to do that if that's in your protocols to do and you do have the equipment, but maybe also consider placing a tourniquet, because that wound packing does not stop the bleeding. It just stops you from seeing it for a while. Letting the victim's discomfort and pain interfere with what you need to. We talked about this already. It's just not a painless technique, not a painless procedure. So talk to them about it. And, if they're screaming at you, calling you bad names, then they're still alert enough to do so. So that's actually a good sign if they stop yelling at you, then we need to be paying attention to something else, right? And doing nothing when a tourniquet and wound packing supplies are not available. Do whatever you can to, maybe you have to have some improvised devices, or do whatever you can to stop that bleeding, because if you do not stop the bleeding will eventually stop and all things are lost for our patient care.
And this is taken from the Stop the Bleed campaign in education. So this is not necessarily directed at medical providers. This is to the general public. So that bottom one of doing nothing when a tourniquet or wound packing supplies are not available, that's more of education to the public of, if you don't have a tourniquet, that doesn't mean that all is lost.
Right.
Like you're saying, we as providers should be bringing the best medical care to our patients. So hopefully we're not in this situation. We should have tourniquets. We should have, if you don't have a tourniquet, a blood pressure cuff could do a darn good job when used in place of a tourniquet. Again, are you going to be able to actually get it to stop the bleeding? Maybe not, but maybe we can get it to slow to the point where it's manageable. Yeah. But all those things, again, this is taken more for the general public.
Yep.
But it's just a great slide to remind ourselves.
Right. So we'll blow through this pretty quickly, how to apply it. Again, if you have them available, practices after we're done.
Disclaimer, do not practice with the tourniquets you plan to use on your patients. Right. Buy training tourniquets that are only for training, because every time you crank that windlass, right, on whatever device, you're damaging the constricting band of that.
Yep.
So buy training tourniquets, mark them very clearly. Do not practice with tourniquets you plan to use to save your life. That goes for at home or at work.
Step 1, we're going to insert the injured limb through the loop. Don't undo that loop 100%, pull it apart, because then that takes time, right? They are set up, or should come from the package, set up to be deployed without taking that band through that. So we want to loosen it up, put their arm through high as possible or whatever your local protocol says. We're going to pull that band as tight as possible to start with, right? A good setup with that band being nice and tight will help the windlass do its job. Then we're going to start to twist the rod until the bleeding, we see that the bleeding is slowed and or stopped. And then we want to assess our peripheral distal pulse with that as well. Make sure we don't have a radial pulse, brachial pulse, or wherever.
And that's a secondary. First is crank that thing down until the bleeding stops.
Yep.
If you have cranked this all the way to the end of its ability and the bleeding has not stopped, this is that reevaluate for the need for a second tourniquet or wound packing or whatever else you need to do. But we don't hold the distal pulse and then crank this tourniquet. This is crank this thing down till we notice a stopping in the bleeding or a very, very slow. And then the distal pulse is that's just checking that we have done the job that needs to be done.
Yep. And again, painful procedure, talk to your patient about it. And try it. Don't let them fight you placing it. So after we're done, it's nice and tight. Bleeding has stopped. No distal pulse. We're going to place that rod inside the clip and lock it in place with that strap. Place the time on there as it says, and we're going to move on. And if it's done appropriately, as we see here in this picture, looks like bleeding has stopped from that massive wound.
Yep. And en route to the hospital, this is a great time. You can do some decontamination. You can do some, covering the wound to ensure, all kinds of stuff. This is not a one and done and then forget about it.
Right.
This is that now we can get him in an ambulance. Things are progressing where we should go. Now we can worry about some of those sterile techniques secondary.
Yep. And
not on scene.
For these patients, critically ill and injured, so we're reassessing vital signs every 5 minutes or more. You should be checking that tourniquet, making sure it's still doing what it's supposed to.
These next couple of slides you can just put them up there. They're just all kinds of statistics of when tourniquets have been used. That's the Boston bombing statistics. CFR is case fatality rate, was a term the military uses to number of injured victims versus fatalities. On the right, we have the Las Vegas shooting. Again, high amount of people, a pretty favorable case fatality rate when you look at number of injuries versus number of deaths, right? So again, these are great numbers. Again, both cases, tourniquets were widely used. From what I could find, Boston bombing, a lot of the tourniquets were improvised because this was early on in tourniquet application in the pre-hospital civilian world. To whereas Las Vegas, we were much more aggressive with having manufactured tourniquets available for first responders. And this next slide is going to be stuff from military, both Operation Iraqi Freedom as well as Operation Enduring Freedom. Civilian-wise, pre-2013, case fatality rate of trauma was 46%. 2013 was the best I kind of found we started using tourniquets a little more widely in the civilian world. And we've increased, again, if you go back to those two incidences, we've increased our case fatality rate with the use of tourniquets in the pre-hospital setting. More numbers here. Again, just talking about, hopefully most agencies are on board with tourniquet use.
Yeah. Bottom line is tourniquets are a great tool when used appropriately in the appropriate setting. So if you have them, use them, be familiar with them. That's the biggest takeaway. Be familiar with them, know how to get them going quickly. Back to our case study now. We went off
our chainsaw.
Chainsaw guy. So again, remember, he cut his leg while utilizing his chainsaw inappropriately. He did have some massive external bleeding that we chose to use direct pressure. That didn't help. So you went on with a tourniquet, applied appropriately. It worked, right? So vital signs now: pulse 136, blood pressure 116/76, respiratory rate 28, and he is 98% on room air oxygen. Is this patient shocky then? I would say maybe a little bit of shock states. I mean, maybe we saw a good amount of blood on the ground. He got himself pretty decently with that chainsaw. We did have to use a tourniquet, so that means that we did have some maybe femoral artery involvement to cause massive amounts of bleeding. So now we're starting to anticipate a shock state, right? So what are our shock states? We have three categories, right? We have the compensated, decompensated, and irreversible. So let's take a look at that. Compensated pulse rate increases, and again, this guy just cut himself, right? So he's going to be in pain, and he just has a, oh crap moment. I just cut myself with my chainsaw. That in itself will raise your pulse rate, right? We have an increased respiratory rate. Again, he's in pain, but this is also compensated shock, right? We could have weak pulses. Skin will be a little bit cool, clammy. They will be anxious, restless, combative. Again, we just placed the tourniquet. He just cut himself with a chainsaw, so we anticipate that. Anyways, right? If he's feeling a little bit thirsty, if he keeps asking for a drink of water, he might be in compensated shock. Our blood loss with stage 1, stage 2 hemorrhages, 50 or 500 to about 1,250 milliliters of blood, which is about 5 to 25% of blood volume lost. Again, remember that normal healthy adults is about 5 to 6 liters, depending. How do we pick that up on the ground? If he's on dirt, the dirt's going to absorb some blood. So this is all a guesstimate, right? We don't need to be collecting all of the blood and bringing it out into a bucket or anything like that, but just take a good guesstimate and always err on the side of caution with that, right? But just know that with his vital signs, the amount of blood that he lost, we can anticipate he's at least in compensated shock, right?
This diagram's great. You look at the stage 1 and stage 2 and things like that. That's more of a hospital determination, right? That's not us. But what I think what's great about this is look at that window of what is compensated shock is huge. So they're going to compensate for a longer time than we think, 5 to 25%. But then when you look at that 25 to 35%, that's your decompensating window, which when we started in EMS, we really didn't think the patient was in shock until our altered level of consciousness. Our blood pressure was 90 systolic or lower. And then we got concerned about shock and then of course that was pre-2013, which meant no wonder why the case fatality rate was so high, because EMS was waiting far too long to be aggressive with this. So this diagram kind of encompasses what the hospitals look at, our overall vital signs has some vulgarity to drive home the point. We didn't create this. This was taken from just a regular Google search. Talks about giving fluids. Again, maybe that's not at the EMT level. Maybe it is, but it's just be aggressive and looking at that shock. That compensating shock window is huge. We still have to recognize that compensating shock window, because when they're in decompensation, we're in trouble. We're way behind the eight ball.
Anticipate that a compensated shock will always go into a decompensated shock. Treat appropriately as you can and get them to the hospital. And then we go decompensated. We start to lose, or we become altered because we're not getting enough blood flow, oxygenated blood to the brain. Blood pressure will start to drop even more. Pulse rate will start to drop. And we go into irreversible shock where we see, down to cellular level death and the multi-organ systems dysfunctions and bad stuff, right? So always anticipate they're going to be in a shock state, treat it appropriately, get them to a hospital, don't mess around, bottom line.
And the one thing I failed to realize that I was taught was just because they're like, you look at 35% blood volume loss, you're going to have someone who says, well, I've seen someone with 3.5 liters of blood on the ground and they were alive. We're not saying that at 35% blood loss, they die. They are likely to die. That could be next week in the hospital. That could be, they could hang out. Like what we're saying is their chance of survival is very, very low.
Yeah.
Just because you're currently seeing them alive doesn't mean they're not going to die because we were not aggressive.
Right.
It just means that because we were not aggressive, their chances of survival, however long that could be, is lower.
Yeah.
So this is not once they lose 35% of their blood volume, they just up and die on you. It's you have just decreased their chance of survival because we failed to recognize this sliding scale.
Yeah. Yeah. Not to get too much more in the weeds on this, but once we start losing a massive amount of oxygenated blood, that's nutrients, that's waste removal, that's everything to our cells. And once our cells die, tissues die, organs die, and that's a slow process. So yeah, if you have we say good in a sick way, trauma case, follow back with that hospital and see how that patient turned out, right? Was your anticipation of the shock good, or were we slow at it and then they were worse outcome than we anticipated them to be? So in this case, we put the tourniquet on, vital signs, we anticipated shock. We did what we can as EMTs, laid them down, placed blanket, kept them warm, maybe advanced level of care for IV or pain management, whatever. We got him to the hospital. Anything else that we want to do with this guy before we wrap it up?
Just wrap him up.
Unintended. Good.
Maintain heat loss. Maintain heat control.
Heat loss.
Yeah, I think that's right.
If he doesn't want to lose, we don't want him to lose.
We don't want him to be hypothermia. Wrap him in a blanket. Does he need a tourniquet? Does he need a backboard? Probably not, but maybe that's the backboard is the best device to move him from the ground to your stretcher. Then you take him off the backboard. Now, I saw a rope. Maybe he fell out of the tree. So maybe there is a need for spinalization, but we're not going to go to that with this one.
Yeah, if you guys want, dive in the weeds on that. But yeah.
What's going to kill him faster?
Get out on boards.
Get him in an ambulance.
Great moving devices. I don't want him up walking around, especially on that bad leg, right? That will loosen our tourniquet and cause pain, and he will be mad. All right. So our last case study, number 3, we're responding to a two-car MVA head-on collision. We have multiple callers reporting at least 2 people have been ejected and at least 4 or 5 people trapped. We're not sure. With this, what are our initial thoughts and actions?
Can we just skip is this reliable information from dispatch? That's the first thing that caught my eyes is 2-car MVA, 4 people trapped, multiple callers. Everyone says this is giant car wreck that's got patients everywhere.
Yeah. I put that question in there for a reason because we always say we don't want to rely on our dispatch information because it's most of the time inaccurate. Again, dispatchers are great.
It's not the dispatcher's fault it's inaccurate. It's the caller's fault.
Yeah, whoever calls and says. But in this instance, whenever we have multiple callers, my index of suspicion that this is really bad goes up. Same thing on the fire side when we're responding to a house fire. If there's multiple callers saying there's smoke or flame showing from a house, then we can anticipate that there's going to be some action. So in our initial thoughts, where are we at?
Yep.
Response area, and how many people do we have coming to help? And do we need to have more people coming to help? This is, again, with multiple callers saying that we have head-on collision. That's, if you have highways around, that's good speed. Speed is bad when it comes to meet. So our mechanisms of injury are going to be extremely high. Multiple patients are going to, oversaturate us with initial actions. And so do we have helicopters available? Do we have more? Do we have mutual aid, auto aid? Who else can we have to come help? Because we might need it. All right. So this is a picture of what you see. So we've got 2 vehicles, obviously, head-on collision. We have a black SUV there and looks like dark gray or black. Yeah. So as we can see, there is a high rate of speed. Yes, new age cars are built to have good crumple zones to take all that energy from impact. But I would say this is we have airbags everywhere that are deployed. There's mass amounts of vehicle material. So we have a good mechanism here. This is bad.
Ambulance side, right? Take fire side out of this. Ambulance is first on scene because it was just down the road, or you don't have a fire response. Things to think about on EMTs on the ambulance side. Is the vehicle stable and safe for you to approach, right? The one on the left-hand side looks like it's teetering on something, right? The one on the right seems a little more stable than the one on the left. So, approach at 45-degree angles. Don't approach directly from the front. Don't approach directly from the back. If you've got to move some of those airbags to make some initial contact with patients, be thinking about, I've seen amazing ambulance crews that grab the ABC or the red fire extinguisher off their car and take it with them to the vehicle. That's great heads up. Good job on scene safety, because is one of these vehicles going to catch fire? Are there fluids leaking that can cause issues? All of those things should be things you have to be thinking if you are an ambulance first on scene. Now on the fire side, if you're an EMT and you're now assigned patient care, now you're operating with protective clothing in most cases, like turnouts, able to have fire suppression, extrication, that kind of thing. But I just want to address ambulance first on scene. Your safety is still paramount. Doesn't matter if the public is waving you over, the guy on the left-hand side's not breathing. Oh my gosh, whatever the case might be. But keeping your head on a swivel, slowing down for a second, and paying attention is vitally important in this.
Yes. Yeah, good. And with the airbags, yes, there's a lot of airbags that are deployed already. Be careful of airbags. If they're not deployed, they may deploy. Again, these new cars have airbags everywhere. So anticipate that and be cautious. And I'm glad you mentioned that on the ambulance side, 2 persons. I don't care where you work or what apparatus you're on. You are a 2-person crew on an ambulance for this next instance, right? So we had reports of 2 patients who were ejected. So we'll pretend I didn't want to put a picture of actual people lying there, right? But we do have 2 people lying in the street. How do we handle this as a 2-person ambulance? Who you were down the street when this came in, and now you are on scene by yourself, and your help's a little bit away. Would you consider this an MCI?
I would.
Absolutely. Yeah. And people are like, well, it's, mass cats with Molden. Remember that mass casualty is any number of patients that overwhelms a local agency and or a hospital system. So 2 things here. You had 2 patients there. You guys split 2 because you're great. You're going to say, I'm going to go triage patients. We have 3 patients in that black SUV, 2 more patients in that dark gray or black sedan. So we have a total of a lot more than providers we have, right? So in this instance, we are oversaturated with tasks. And so this would be considered an NMCI. So how do we handle that? This is where for years I've taught it, I've experienced it, where it comes down to actually triaging patients, right? We are providers because we are in this field because we care about people, and we want to help everybody that we can. But when we are presented with something like this, right, the worst case scenario, we have two vehicles, good rate of speed, high mechanism. We have multiple patients that we have to deal with. We have to quickly evaluate those that we can help and those that we can't do anything for at all or right now, right? So, and again, this is not something that is easy to do. I've had to do it more times than I want. But you look at somebody who say they are obviously dead. We use whatever triage tools that we have, jump start, start triage, whatever. You look at that patient, you say this person is dead, right? You have to have the ability, and it's not going to be easy, to say this person's dead. I can't do anything for this person by myself and quickly to save them. I need to move on and see who I can help. So this is not one of those easy. And I made this, the last two case studies, they're taxing on purpose, but let's take a look at what it really means to get into a oh crap scenario, right? So our triage must be quick, and we must have means to label these patients, green, yellow, red, or the new lingo we talk, zebra and gray, right? So zebra means they are dead with our simple tasks, opening, adjusting respirations or airways. They don't have any pulses. They're dead, right? Gray means we're anticipating that they are on their way to death, right? They're that irreversible shock state or whatever. They're on their way. There's nothing we can do about them. Those people we unfortunately have to put aside. Let's go focus on our reds, greens, and yellow patients.
When I think it's important, two separate incidents, right? Call number one is a auto versus pedestrian. You show up, pedestrian's laying on the ground. We have open femur fractures. We have a depressed skull fracture. We have a patient who is agonally breathing on the ground. He's our isolated patient. We show up as an ambulance. You're 100% going to bag valve mask that patient. Yeah. You're going to start patient care. He loses his pulse. You're going to immediately start chest compressions and run that cardiac arrest that's trauma driven. Call number two is same exact patient presentation, auto versus pedestrian, but now there are 4 other patients in that car. You go to that patient. Maybe that patient now gets gray tagged or zebra tagged. We're not doing chest compressions. We're not, like, as a critical thinking EMT, you have to determine this is 2 different calls, right? Yep. There will be patients that you look at in an MCI that in normal cases, you would consider that to be survivable. Okay. And you would start a cardiac arrest algorithm. In an MCI, the answer is no. Yeah. Now, you completely triage. Everyone is being taken care of. You get 9 ambulances and 5 fire engines, and you happen to come back to that person, and now you have all the resources in the world, and they're still managing to hang on to life. Then yes, maybe now you start initiating patient care, but being able to critically think through that is vitally important. Yeah. Yeah. Being good thinking EMTs on your feet and doing the best you can for what you have presented at that time. And again, we reevaluate everything, right? Just as, we classify somebody red, yellow, green, we want to reevaluate them and make sure that they are still in that category, or are they progressively getting worse. Again, as we need, we got that gray patient who we assume is going to die. We come back, they're still alive. Like Shaun said, we have the resources. Heck yeah, let's try and save them. It's a hard thing to do, right? And I'll leave it at that. And the education is not going to change that. We can give you the education. It's not going to change the internal battle you're going to. I can talk to you about it, till I'm blue in the face. But trust me, I've experienced it. It's not an easy thing to do, but we have to do the best we can. Initially, you get there as a 2-person ambulance. You're like, oh crap, give me the world. The world shows up. Okay, so we're not going to talk about, the ICS side of setting everything up, but you were assigned to one of the patients in the back of the SUV. So you have a 24-year-old patient. She's on the back passenger side on the passenger of the backseat passenger on the passenger side. So confusing, but in that crumpled car, she's one of your patients, 24-year-old female. She is altered. You look in the vehicle, she does have multiple fractures that you can see. She does have a compound fracture, so the bone's sticking out on the right forearm. What are our initial actions for that? To me, this is, I'm going to march, right? Does she have any manageable, massive hemorrhage that I can fix, right? If those fractures are actively bleeding to the point where, I'm not going to do direct pressure, because if this is an MCI, I got like 30 seconds, right? If it needs a tourniquet, it's getting a tourniquet. If it needs a pressure bandage, it can have a pressure bandage. If it needs a chest seal, it's getting a chest seal. Other than that, this person is going to get triaged and tagged and move on to the next one.
Perfect. Yep. So yeah, massive. And this is why we always stress have a systematic approach to whatever you do and do that every time, right? Because in this instance, you look at this patient, you're like, holy cow, I have to do everything all at once. Start at the top. Massive hemorrhaging will kill her faster than anything else. Address that. She's altered. I'm going to assume that's a shock state until proven otherwise. We need to get her out of the car so that we can do more. Okay, so she was extricated, placed on a long spinal board for you. This is where one of those instances where that will be called for. Again, starting at the top, we addressed the compound fracture. We put a tourniquet on that to stop the bleeding. It was effective. We do our rapid trauma assessment from head to toe. So she has some contusions and hematomas on the right side of her forehead. That is, I would anticipate that for where she was sitting in that vehicle and how that impact got her. Compound fracture of the right forearm that we already found. We controlled the bleeding with the tourniquet. Feel the abdomen, it is rigid. So we should anticipate the fact that she might have some internal hemorrhaging. And she has bilateral closed femur fractures. Sick patient. And no, you cannot exchange her for another patient. This is who you have. So what are we going to do for her? A couple things. One, we took care of that massive hemorrhaging on the outside with that forearm, right? We did an exam. We didn't find any other extenuating hemorrhage. We have to address her airway. Is it open? Is it patent? Does she have any missing teeth? There's any blood that might be causing issues? And can we place a nasal cannula or a nasal NPA because, she is altered. So we want to take a look at that. Her breathing, how fast, how slow, is she, is it shallow? Is it labored? What's that look like? Her abdomen is rigid. So I'm going to anticipate she does have some internal hemorrhage that we can't see. So that brings we need to hurry up faster. That bilateral closed femur fractures, again, in this instance, multi-systems trauma, with the mechanism, I'm going to assume that more than just the femurs are involved. And so, no, we're not going to do traction splints. In this instance, this long spinal board that she must be on because she's altered is going to be a great long splint for us. It will splint everything down. We're going to utilize our spider straps appropriately and everything will be addressed with that. Right.
Use the spider straps to be tight in areas around those fractures to stabilize them, but not too tight on chest cavities, around areas that's going to impede her breathing or your ability to bag valve mass this patient appropriately.
Yep. And we didn't mention it, but C-collar appropriate. Yes, absolutely. All right. So vital signs we take on her, we get her, we get all that other stuff addressed. Her GCS is 8. We don't dive into GCS much in this. We can do a whole nother segment of that and know your Glasgow Coma scale. This was made for the trauma scenario. So this is important, right? So her GCS is 8. So her eyes open to 2, meaning that pain, she does kind of open them. Verbal is 2. So she's making incomprehensible sounds. And motor is 4, so she does withdraw with pain response.
No posturing, though. So no decorticate or decerebrate, because that would be your 3 and 2 in that motor scale.
Right. But that is something that we might want to pay attention to, especially since we saw the contusions and hematomas on her forehead, right? Pulse rate is 64, blood pressure 190 over 110, respiratory rate is 10 and irregular, oxygen saturation on room air is 85%. So first question here, is she in shock?
Yes.
I would say yeah. But then you would come back and you say, well, okay, we looked at that chart and compensated shock, she'll have a faster heart rate and we always talk about normal blood pressures. In this instance, she doesn't have a fast heart rate and her blood pressure is extremely high. When things don't make sense from what we know, what we anticipate to the vital signs that we get back, and it doesn't make sense, we have to think to ourselves, why is that? Right? So in this instance, we had exsanguinating hemorrhage in that forearm that we controlled. We have a rigid abdomen, so we anticipate that she does have some internal bleeding. Nothing we can do about it. She's altered, so we think maybe decompensated shock, but our vital signs aren't showing that, right? So could something else be going on at the same time? Absolutely. In this instance, with the injuries that she had to her head and being altered, I would highly suspect that she has a traumatic brain injury.
Remember the term Cushing's triad is hanging out right here and should be hanging out in your brain.
Yep.
If you're not familiar with that, go look it up, right? This is a classic. You have all 3 signs of Cushing's, right? You have your bradycardia, which 64 is borderline bradycardia, but not only do we have hypertension, but we also have kind of a wide blood pressure. and then we have irregular respiratory rate. Like this is that head injury.
Yeah. So the pulse rate is 64. You're like, wow, that's better than what mine is just sitting here, right? But given the circumstances, she was
tachycardic.
She should be tachycardic. So that is off. And 10 respirations, but they're irregular. That's, sign of some issues, right? So an SpO2, 85%, are we going to address that? Absolutely. We need to get oxygen saturations up to not 100%, but we do need to get the blood that she has oxygenated so that we can perfuse end organs. Address what you can address. Again, yes, this is a complex multi-systems trauma patient. But, these are the things that you need to anticipate and work on so that if you are presented or when you are presented with one of these patients, then you're not lost in the weeds. Again, we went through 3 case scenarios, talked about rapid patient trauma assessment. Some of the tools, again, with our wounds, where are they or what are they and what do we do? So, in the blue there, just looking at tourniquets, one of our tools, we tourniquet extremities. Up into the high proximal femur area is about our cutoffs, just because we can't get them past our hips. Wound packing, anything in the gray. Chest seals go on the core, right? The thorax. We shall not wound pack anything in the core that is a large cavity. You're just putting gauze. You don't know what it's doing, right? So we want to keep those for areas where we can't tourniquet, but we want to put some pressure on those arteries. Chest seals appropriate for, chest, back, abdomen, wherever we have. And then pressure dressings, if you have them, what brand are they?
Yeah, doesn't matter. Right?
As long as you know how to use them.
Yeah, easy little saying in your head. We tourniquet the limbs, we wound pack the junctions, and we seal our box, right? So looking at this, tourniquet the blue, wound pack the gray, and you're going to chest seal everything in the white. The big thing is this is 3-dimensional. So if that's on the lateral side of the chest cavity, still gets a chest seal.
Yep.
If it's on the posterior side of the chest cavity, it's still getting a chest seal. So this is a 3-dimensional diagram over there on the left-hand side. Tourniquet the limbs, pack the junctions, seal the box. We go to this car and we're in a triage situation or even an initial care situation. Those are the things we can do inside the car. And then once she's extricated, we can start worrying about some of those other things if you're relating it back to that scenario.
All right. So pretty heavy content lecture today, but again, all things were important. So this is kind of a wrap up for us. So number one, we want to ensure safety for all. Whatever scenario you're getting yourself into, make sure you're not becoming a patient. Always address and anticipate the needs for more people or other additional resources, whether it be helicopters, law enforcement, whatever you need. What physics cause trauma, right? So know that, blunt force, penetrating trauma, whatever you can get yourself into, blast injuries, just know it, right? Study it, know it, be good at it. Primary survey, again, going through our XABCDEs or our March to address life-threatening conditions. And again, remember, when we're doing our rapid trauma exam, some things we can take note of and work past. Any life-threatening injury must be addressed at that point, right? So a person has closed femur fractured, great, we'll address it when we get a chance, but person has missing arm is massively bleeding everywhere. That is a life threat. Take care of that now. Always anticipate need for spinal immobilization and controlling the airway. Support ventilation as necessary. BVMs, NPAs, OPAs as appropriate. Keep oxygen up greater than 94%. Controlling our bleeding we talked about. Basic shock therapy. Make sure our trauma patients are warm and stay warm. We want to anticipate that they could go down that trauma triad of death, and we want to stop what we can stop, right? Maintaining. So once we take manual C-spine, we control that C-spine until we have mechanical devices, the C-collar, and if we're putting them on a backboard, headbed, strap down.
And know with that, just real quick, know the spinal motion restriction guidelines, right? The change in that, take a look at that. Pre-hospital trauma life support has great stuff. There's lots of great literature out there about the transition from quote unquote spinal immobilization to what's now called spinal motion restriction.
Critically ill patients, that's, protocol driven. Use what you have, closest appropriate facility for any life threats. But if you have trauma centers that are available, know your local hospitals and your local areas and protocols, whatever they want to do for that. As necessary, past medical history, passport and medical history, sample, OPQST appropriate. That can be done en route if we have a critically ill patient. We want to try and maintain those times, and documentation, right? Good vital sign recording, procedure recording, good communications on the cell phone or radio if you use it. And then when you get to the hospital, to whatever provider you're passing off to, document very accurately, especially on those where there may be some criminal element, any MVAs or any signs of violent assaults. Those will be litigated. So make sure you're doing good documentation.
Sweet. Nice work.
Hey, thanks for checking out another episode of EMSconnect on Shift. Please subscribe, review, and rate our podcast on your favorite platforms. Those ratings really help our podcast grow and reach new listeners. Also, make sure to like and follow our social media sites by searching EMSconnect on Facebook, Instagram, and YouTube. Thanks for getting educated with EMSconnect.